Okay, it says Tosha is the host.
Oh, I think she's
Yeah,
she's
Tosha just logged on and she's now the host, so she should be able to give us privileges.
Okay. Hey, Tosha, would you mind allowing Emilio and Raj to share? I think
I
Emilio,
can share my screen,
You
I
should be
guess.
allowed now.
Okay.
terrific. Thank you.
Can you see my screen?
yes.
Yep.
Okay, but it's not in full mode, or?
No,
Now it is.
now it is. Yeah.
Now it is, right?
Yep.
Yes.
Okay.
Jean de
So
Dieu, that's the one I know. Okay.
Want me to give it a try?
Yeah, that'd be great. Thanks very much. And just for our moderators, if you could just make sure that you announce that we can see that. Thank you. And
Right.
perfect full screen. Thank you.
Stop sharing.
For our moderators, if you could please just let people know that it is being recorded, and then at the end that it'll be available at the on the website. And for our speakers, if you could just make a comment that if you have any disclosures or if you have no disclosures, also please state that. Great. Thanks very much, everybody.
Mary Louise,
Yeah.
who starts with the presentations?
Did you just decide that Raj, you're going to go first and Emilio's going to go second, or what would you prefer? I think it's listed as you first, Emilio, on the
Okay.
let me just check. I think that's what I had.
I think so as well.
But whatever you prefer, like if either of you have a.
Yeah, I can start.
Yes, I have it. I think I have you listed first, and then Raj, you're listed second, if that's okay.
Okay, should I just leave the front page shared?
Yes, it is. Thank you. Hi, Mike.
Hi, everyone. Sorry, I'm still in the reading room. I'll be up in a second.
Hi, Mike.
And no, thanks, Tosha. That's all great. So I'm going to step back and leave it to the good care of our very capable moderators.
Lisa, do you want to do the opening and introduction for the first presenter, or you want me to do it?
I think you can do it. I don't know.
Okay. Okay, sure. Then you can do the second one and the closing message as well. I think we should wait for a few more minutes to let people join. Okay, I think we should start. Hello, everyone. I would like to start the meeting by welcoming you all. Good morning, good afternoon, and good evening. My name is Ming Hui. I'm the moderator, one of the moderators today. I'm from Children's Hospital of Philadelphia. I'm very excited to be introducing today's WFPI and ISMRM joint virtual meeting entitled Pediatric Whole Body MRI Protocols with our guest speaker, Dr. Emily Roy, in the red host, and Dr. Raj Krishnamurthy. I would also like to introduce Dr. Lisa Suzuki, who is from Brazil, will be helping moderate today's meeting as well. I'm moderating on behalf of ISMN and Lisa on behalf of the WFPI. Lisa has kindly co-moderated one of these webinars for us before, so thank you for helping us out again, Lisa. Feel free to post any question for the presenters in the chat box. You can pass through this, you can post the question through the session, and we will have a Q&A at the end of each talk. It's about 10 minutes. And please mute your microphone. And the session will be recorded and later uploaded to the WFPI and the ISMRM website. So I would like to introduce our first presenter today, Dr. Emilio in the red horse. He's the Director of Diagnostic Imaging and Nuclear Medicine and Interventional Radiologist of SJD Barcelona Children's Hospital since 2023. He's a member of ISMRM PBC Pediatric Radiology Subspecialty Committee and previous Director of Publication of the Spanish Society of Radiology and Chair of the Pediatrics Subcommittee of the Spanish Society of MSK Radiology. His interests include MSK radiology with a focus on pediatric rheumatology and MSK oncology. He's particularly dedicated to optimizing imaging protocols to reduce scan time and minimize the need for anesthesias, enhancing both patient safety and efficiency. Today, he will be presenting on tumor predisposition imaging when and how.
Okay, so thank you for the presentation, and also thank you to the audience for connecting to this meeting. And I want to thank Marie-Louise for this kind invitation to participate in the World Federation of Pediatric Imaging. It's an honor to participate. So let's start with my talk about tumor predispositions. I don't have anything to disclose. So tumor predispositions are rare genetic conditions where specific children have higher risk of developing tumors compared to other children who are normal. So screening is going to be crucial because we want to identify tumors earlier to improve the treatment options and also to improve the survival outcomes. The surveillance can be performed in two ways. On one side, in symptomatic patients with the presence of a tumor, or in asymptomatic patients with the presence of risk factors. But the most important thing is the way we manage those patients. The management should be performed in tertiary hospitals,
Ya, entonces no
what we call
Entonces, acá, ¿cuáles serían los diferenciales?
Audience,
Si
please
no,
mute
on
your
the 51,
microphone.
51, Twitter, ¿no? Ya, ¿cuáles
Is
son las lesiones de...
Kristen, could you please mute your microphone?
Okay, I think he muted. So the management should be performed in tertiary hospitals with a multidisciplinary team, which should include oncologists, geneticists, endocrinologists, pathologists, and obviously radiologists. The American Association for Cancer Research has established general screening recommendations and has developed the surveillance protocols for a wide range of cancer predisposition syndromes. In fact, if you go to the website, you will see that there are more than 50 entities or cancer predisposition syndromes. And in fact, you will see that in this association, Mary Louise Greer is one of the radiologists which is in charge of the optimizing the protocols of whole body MRI. So screening is going to be challenging, especially in asymptomatic children, because sometimes we don't know how and when to image. And sometimes when we are evaluating those kids, we are going to come across to what we call incidental findings, and we have to know how to manage these incidental findings. First of all, we have to define what is an incidental finding. An incidental finding is an unexpected finding that is not related to the patient's condition and leads to further evaluation. That means that you may need more imaging or biopsy or even a surgery. And in fact, in Li-Fraumeni syndrome, those incidental findings can range up to 30%, which is a lot. And let me show you an incidental from the paper of Dr. Greer. You can see here that this patient has Li-Fraumeni, and in the follow-up, they could see this abnormal signal intensity in the sacroiliac joints. And this turned out to be bilateral sacroiliitis, which is very uncommon, but it can happen. It is more frequent, for example, to find bone marrow edema. This is a patient from my institution, Li-Fraumeni, follow-up with the coronal stir, and it is normal to find sometimes this abnormal signal intensity or bone marrow edema around the perifacial areas. This is very, very common, and we call that FOPE. This is another case. Initially, that patient with Li-Fraumeni was completely normal, no tumor, but 6 months later, we could see what at that time we call that bone marrow edema. So we call that a non-specific bone marrow edema, and we decided to do a close follow-up. So 12 months later, we could see that the signal intensity was less evident, and finally, 18th month later, we could see that there was complete resolution of what we call at that time bone marrow edema. But in fact, this is not bone marrow edema. This is an entity that you should know, and it's called residual red bone marrow. And you should know that because it's a common finding in the pediatric population. It normally presents as a hyperintense foci on stereo images in different anatomic regions of the body, especially in the subchondral region of the metaphysis of long bones with this geographic or flame-shaped pattern. The thing is, when you see those lesions, but those are associated with a soft tissue mass or soft tissue edema, this is not typical of residual red bone marrow. And you may need to add other sequences, such as, for example, diffusion, to see whether this is malignant or this is benign. In terms of consensus, the consensus recommendation is based on estimated prevalence of cancer development in more than 50 pediatric cancer predisposition syndromes. In fact, it is the association says that when the prevalence is above 5%, the screening is fully recommended. But when the prevalence is below 1%, the screening is not recommended. And when the prevalence is between 1 and 5, it has to be assessed individually. And in terms of the imaging protocols, we all know that children with CPS, like Li-Fraumeni, are more sensitive to the adverse effects of radiation. And we have to avoid radiation. We have to avoid CT. We have to avoid, as much as possible, X-ray. And for that reason, the American Association of Cancer Research recommends whole body MR and abdominal ultrasound in most of the CPS. In fact, if you go over, please, could you please
remember how you were like
okay, I'm going to
Yeah, sorry.
okay. So in fact, if you go over the 50 pediatric cancer syndromes, you will see that there is only one syndrome, which is called the Dicer-1 syndrome, in which it's only included the chest CT to screen for pleuropulmonary blastoma. And if we talk about recommendations, I have to talk about the recommendations of our society in Europe, the European Society of Pediatric Radiology. This is a nice paper that was published back in 2020 by the Oncology Task Force of the SPR that made several recommendations about the use of whole body MR in pediatric oncology. As you can see here, they picked 5 entities, and this is a summary, a table summary that I did of all these entities. You can see that When it comes to the predisposition cancer syndromes, the whole body MR is fully recommended. However, if we are dealing, for example, with a lymphoma, it's a PET-CT what is recommended. If we have a neuroblastoma, it's an MIBG. Sarcoma, PET-CT, and LCH, the whole body MR is not recommended for the evaluation of the extraosseous disease and the follow-up. So whole body MR can be performed either in 1.5 or 3 Tesla, but the most important thing is that the patient should be covered with all the coils. You can see here that the patient is covered by all the coils, and one point that should be taken into consideration is that we are dealing with young kids, and most of them, they may need anesthesia. So one thing that we are trying is to avoid or to decrease the rate of anesthesia. One method to avoid the anesthesia, and this is one thing that we are doing since many years ago, we are using these goggles, and through these goggles we project video projections and cartoons, and this is a way to decrease the rate of anesthesia. This is the protocol that we normally use in the oncologic patients. It lasts approximately 40 minutes, and we include T1 Dixon, which offer the possibility of having 4 sequences at once, a stir, and also diffusion. And this is how I do it. In terms of Dixon T1, it's acquired in coronal. So depending on the length of the patient, I'm going to need more or less stacks. In that patient, for example, I only needed it